quick look at some of the other industry trends and forecasts. We mentioned earlier the payment condition count model. So this is some graphs, and in the advance notice, CMS proposed two different ways to look at other conditions the member had. There was a payment condition count, which only uses conditions that are within the CMS-HCC model, and the all condition count, which expands the definition. It's for all conditions, so they could be in or outside the model. But that skewed the impact, and it's very much way more erratic. So if you look on the right, the all condition count, the payments were all over the place, but the payment condition count model, the variance was more toward the positive and not as far off the line or off the status quo. CMS is going to use the payment condition count model, believing that it will improve the accuracy of the risk adjustment model. It's the conditions used in the payment model tend to be more clinically severe, and the majority classified as chronic. In contrast, if they use the all-condition approach, it would count many conditions that don't meet the criteria of being clinically meaningful and cost predictive, and would include more acute and items that are traditionally being treated as a single therapy course. They feel, CMS feels, the payment condition model is more industry friendly than the status quo and a better cost predictor than the all condition count model. So we sort of look at this as a more global disease interaction measurement. So you're going to count how many conditions within the model you have and make payment adjustments accordingly. Expansion of supplemental. This slide is more directed to the health plans on the call. It doesn't really relate to providers unless you happen to be a provider that sits in on the benefit design with your plan. And it is, I think it's beneficial to understand that CMS is looking for ways to make the MAs more attractive. So they're letting you have more leeway and benefit to the design to include more supplemental information, or excuse me, supplemental coverage. So a little more information sort of outside the call letter, but CMS has been doing this for a number of years. These are the dates of service and payment years that CMS will be running for recoupment in 2018. While it doesn't remove the obligation to return overpayments within 60 days when you find them, this is showing you the payment years and the dates of service that they will be running overpayment recovery. So this is only for deletes. You can't go back and add things, but it's interesting. We've seen a big spike in deletes because we have all realized in the industry that it's better to self-police than to get an audit finding and have that error rate extrapolated over your entire payment. So we do see a lot of our clients doing many, many more deletes for prior years than we had, say 5 years ago. So I mentioned recalibration a little earlier in the presentation. So in case anyone feels CMS is not moving in the direction of repricing based on the MAO data, you would be forgiven if you missed it because it's not something CMS is actually trumpeting. In our review of the CMS responses to comments to the 18 advance notice, within the coding intensity questions, we found some illuminating information foreshadowing CMS's future move in this direction. So this should give everybody much cause for concern. While the primary topic and question being answered is relative to coding intensity, the more significant item to notice is the statement about using MAN counter data to reprice the model. Now, if you go to if we move forward here, we are looking at the basics of calibration, and this is a slide that we have used in the past, and it's extremely oversimplified, but it's showing how the cost could vary between fee-for-service and MAO for the same condition, purely based on the CPT submitted. Since costs as calculated by CMS are always based on fee-for-service pricing methodology, in other words, on CPT codes. So repricing based on the MAO EDPS submissions could potentially be far lower than anything we've experienced with fee-for-service-based pricing. In the example, we see a large disparity in cost between fee-for-service submitted CPTs and the MAO submitted CPTs, both for the same diagnostic conditions. As you can see, disease cost using fee-for-service is $1,173, while for the MAO, for the same condition, is $456. So it's true that our risk score as a raw number could be higher than it is today, but if the underlying cost basis is lower, then the corresponding reimbursement will be lower. So a risk score of 0.980 with a base rate of 1,000 is much higher PMPM than a score of 1.5 with a base score of 400. So it equates to a difference between 980 PMPM versus 600 for the same condition, all based on the CPT codes driving the cost. And the fact that traditional Medicare has been doing this for a long time. So CPT is the cost calibrator, and in fee-for-service, payment is based on activities versus health conditions. So maybe you're sitting here looking at this going, well, why does that matter? Well, because the deficiencies in the submission of CPTs impact the perceived cost of treatment based on CMS's method of calculation. Again, fee-for-service has been doing these CPT submissions since the 60s, so they've had in excess of 60 years, let's see, 60s, that would be 40, in excess of 50 years to perfect coding and submission of activities. We've had far less, and our emphasis has always been documentation for conditions. So it's important that we keep this at the forefront when we're working with encounter data submissions. And even in all of our discussions, we talk about getting all the diagnosis in, but tied to that, we must make sure that we get in all the CPTs that we, as if it was a fee-for-service claim, to make sure that when it's calibrated based on our, and I say this with air quotes, our CPT codes, that it is, as robust and reflective of the cost as possible.